Good afternoon. My name is Yanti, and I am the Health Policy and Research Assistant focusing on birth equity with the Institute for Medicaid Innovation. I'd like to welcome and thank everyone for joining us for the 7th session in the Doula and Perinatal Community Health Worker in Medicaid Virtual Learning Series. I want to start by thanking our partners, Every Mother Counts, as well as our funder, the Community Health Acceleration Partnership, for their commitment to advancing important perinatal health topics in the Medicaid population. We are able to offer this free learning series because of their generous and ongoing support. This learning series includes 8 monthly 1-hour Zoom sessions. Topics will address relevant policy issues with pre-session materials, supplemental resources, and invited subject matter experts. As a refresher, the links to today's pre-session materials have been placed in the chat. Sessions are recorded and will be archived on the IMI website. I want to also let everyone know that all links on the website have been fixed and are accessible to all participants now. We recently transitioned to a new platform, and in that process, some of the materials from previous sessions were inaccessible, but that issue has been corrected, and now this error is no longer, and you can access all the links on the website. All attendees are automatically muted. To participate in the discussion with speakers, please use the Q&A feature to submit questions and comments. We encourage you to submit questions throughout the session. Any unanswered questions will be consolidated and shared with our presenters and project team after today's session, and then we'll send out responses with the post-session material. At the completion of this session, you will receive an email message with a link to complete a short 3-minute feedback survey. As a reminder, completion of the survey is required as part of your participation in the learning series. We look forward to hearing your thoughts as we actively review and incorporate your feedback into future sessions. And finally, all materials, including the slides and session recording, will be available to you in the IMI website about 2 weeks after the session. So for today's session, we're going to highlight examples of collaboration between community-based doulas, perinatal community health workers, and other healthcare and service providers that advance birth equity. We're going to talk about understanding the role that community-based organizations and agencies play in ensuring that community-based doulas and perinatal community health workers can best meet the needs of Medicaid enrolled clients. And finally, we're going to examine priorities and pathways for workforce development, mentorship, and support for community-based doulas and perinatal community health workers. And before we hear from our speakers for this session, we want to continue the tradition of emphasizing the importance of avoiding placing the burden of addressing all maternal health inequities solely on the shoulders of doulas and perinatal community health workers. Access and coverage of doulas and perinatal community health worker services in Medicaid is just one element of a multi-pronged approach that is needed to support system-wide transformation. So I'm very happy to say that we are excited and thrilled that Dr. Kim Bauer is our moderator for this session. She is the medical director for Blue Shield of California Promise Health Plan, and I'm going to hand it off to her now. Thank you so much, Dr. Bauer.
All right, thank you. And thanks to everyone for joining today. I'm really excited about this session. As was stated, I'm the medical director for Medicaid managed care plan in California, and we are currently in the process. We, starting in January, started implementing our doula benefits. So I think one of the really important pieces of the implementation has been how do the doulas in our case, but also the perinatal community health workers interact both with within the medical field and also with other community-based organizations. So I am really excited to get the insights from our panelists today. So I'm going to go ahead and introduce them. So I'm excited to introduce a wonderful group of panelists. Bridget Jager is the doula coordinator the doula coordinator at Grove Doula in Florida. Mary Powell Thomas is the director of Healthy Start in Brooklyn, New York. And then we have two participants from Birthmark Doula Collective in New Orleans. We have Tasia Stewart, who's the contract coordinator, and we have Stephanie Visco, who's the development coordinator. So we've placed a link in the chat so you can see the full bios for each of the speakers today. So for today's session, we're going to get started with a brief presentation from all of our 3 groups of providers. So you can get a sense of how their organizations are structured, and their perspective, and then we'll go into our panel question and answer session. So to get us started, I'm going to hand things over to our first presenter. So I think, let's see, I think we are starting with Bridget, is that correct?
Yes, thank you, Dr. Bowers. I appreciate it. And I appreciate you all having Grow Doula on to be able to speak to each and every one of you. Next slide. So back in 2016, Indian River County Healthy Start Coalition, which is located in Florida, our CEO at the time was learning about Healthy Start, what it does, and went on a site visit with one of our health educators. During this visit, she had learned that the educator had just spent time with the mom who was about 15 years old then, Spanish speaking only, and she had just given birth a couple of days before. Of course, she did not understand what was going on in that visit, but she was able to speak with the coordinator afterwards to get a little background about what was happening and why this mom birthed alone. She had no support, and the baby's father was not there at the time either. So at this time, she went to our partner, which is Cleveland Clinic Indian River, to talk with the director of women's health to just say, hey, how many women do we have in Indian River County that birth alone? We're a very small county, and she said about 100 out of the 1,200 that we have birthed. At that point, she decided that she wanted to start a doula program. There was lots of pushback and everything just because of the relationship that had previously been going on with doulas in the community. But with that partnership and them building a bond with each other, we have been able to build up Grow Doula. Next slide. So the 5 elements of Grow Doula, we like to start with making connections within our community. Talking with our lead agency of the Grow Doula about the Grow Doula program, making sure they understand what doulas do and how we are able to help and assist them through this. We empower our community through trainings. We have a support person, so like myself, that supports our doulas through whatever they need to happen. So we make referrals to our doulas, and we're supporting them through if they needed to talk through a traumatic birth, or they just want to share excitement that had happened at their birth at that time. If there's issues with billing or with getting paperwork in, we are also able to help them with that as well. We also do tracking our outcomes along with our hospital records and our filing that creates an accurate and impactful data. And then we do a continuum of doula care. So we strive for 5 prenatal visits. We are with our client until breastfeeding has been initiated. And then we provide up to 3 postpartum visits. Next slide. So this is some of the data when we launched our program within our first 3 years. So we had a reduction of preterm births in our community that had one of our Grow Doulas. We had a decrease in our cesarean rates, about 25%. We have fewer babies that were born with low birth weights. And we also seen a huge increase of our women that are Black women that initiated breastfeeding, 84%. We had a reduction in preterm birth of our Black women, 7.9%. And we had an overall decrease of cesarean rates in our Hispanic white women as well. So that is a little bit of overview about Grow Doula and a little bit of our accomplishments that we have had in our program. Thank you.
Thank you so much, Bridget. And we are going to go on to our next presenter. So I'm going to hand it over now to Mary Powell.
Great, thank you so much. So I'm Mary Powell Thomas. I'm from the New York City Department of Health and Mental Hygiene. I direct Healthy Start Brooklyn, which operates the By My Side Birth Support Program, and then also the citywide doula initiative. which is a partnership between By My Side and 7 other community-based doula programs. Next slide. So this timeline gives an overview of everything we've done to build the doula workforce and collaborate to support pregnant women and birthing people. At the top of the slide, you'll see that By My Side began as a collaboration with Healthy Start Brooklyn's childbirth education classes. The instructor noticed that her students didn't always know who was going to be with them during labor and birth. So she designed a program to match them with doula support. We launched By My Side in 2010, then conducted 4 trainings over the next few years to help community members become doulas. We realized they needed more support than just training. So in 2018, we started an apprenticeship program, matching them to mentors and providing support with certification. That same year, the health department launched the Maternity Hospital Quality Improvement Network, which includes a component to encourage doula friendliness in hospitals. And all those things came together last year with the launch of the citywide doula initiative. And then the items below the timeline show everything else that was going on at the same time. An annual retreat to support our doula team, a coalition to promote Medicaid reimbursement, a doula program funded by the New York City Council, papers and reports and standards of care, and the New York State Medicaid pilot. Next slide. So what is the By My Side Birth Support Program and the Citywide Doula Initiative? The model combines aspects of private doula care, community-based doula work, and case management. We increased the number of home visits, and we incorporated screenings for depression, anxiety, food insecurity, intimate partner violence, and medical risk factors. We focus a lot on social support, which is especially helpful for clients who don't have a strong social network. Our doulas talk with their clients about breastfeeding, reproductive life planning, child development, safe sleep. They encourage reading to the baby. We try to address material needs also, helping families get diapers, a car seat, a pack and play, things like that. And we focus a lot on the doula's traditional role of facilitating communication with the provider, which is especially important for clients who have less power in the hospital setting. We pay our doulas professional rates, even though some of them can earn a lot more in their private work. And we just actually raised the rates for our apprentice doulas because many of them are still working a 9-to-5 job. And we found that at the lower rates, they couldn't always take time away for doula work. We pay our doulas for meetings, professional development, and going to see a client who doesn't show up, the same as we would if they were an employee. And we also pay them for entering data into our database and for mentoring newer doulas. Next slide. With 13 years of experience, we've learned a lot about what works, what really makes this a strong and sustainable program. We've identified 3 key elements. First, our doula team is front and center in shaping our program. A doula designed the program, and doulas guide the planning and decision-making. They advocate for improvements, they share best practices, and they support each other. Another important element is our strong infrastructure. Too many doula programs have to rely on volunteers and uncertain funding. Having steady financial support from the Healthy Start grant and now from New York City allows us to have a strong administrative team to support our doulas and a thorough and timely intake and matching process for new clients. We also have a structured visit schedule and curriculum and a robust backup system. And finally, we have a strong data collection and evaluation process. We're constantly analyzing our data to demonstrate our impact on birth outcomes and experiences, improve quality, and secure funding. Next slide. So as I mentioned, the By My Side training and apprenticeship model has now been expanded to the Citywide Doula Initiative. We contract with one of our CDI partners to train 50 community members a year as doulas, and then they join one of our 8 programs for a 6-month apprenticeship. We also require professional development for all our CDI doulas in the topics that you see here, including the basics of our model, birth equity, and a number of other things to help them in their work supporting Medicaid clients. We pay them for their time in attending each of these trainings, as well as some optional trainings on things like breastfeeding support and working with clients who are involved with the child welfare system. Next slide. Next slide. So at the beginning, I mentioned that as we were developing our model, there were some other things going on at the same time. One is that our colleagues in the health department launched the New York City standards for respectful care at birth. These were informed by a community process centered around a sexual and reproductive justice community engagement group. And so this publication highlights 6 standards, including the right to easily understandable information, truly informed consent, making decisions for yourself and your baby, high quality care, having the support people you choose, and then dignified and non-discriminatory care. And these are available on the New York City website. Next slide. The other initiative was the Maternity Hospital Quality Improvement Network, which was created to address inequities in maternal mortality and severe maternal morbidity. So MHQIN includes case reviews, quality improvement, trainings, all sorts of things, and also a community engagement piece to strengthen hospital collaboration with doulas. So the MHQIN team works with community-based doula organizations to conduct meet and greets with hospital staff, grand rounds presentations on doula support. They review hospital policies and procedures to help the hospital create a more welcoming environment for both doulas and families. And then they help increase referrals of patients for doula support. Next slide. So all these things came together last year in the Citywide Doula Initiative, which is a multi-million-dollar investment by the New York City Health Department as part of its new family home visits program. The CDI has three components: the doula-friendly hospital work I just described, which is now funded by the CDI, providing no-cost doula care in underserved neighborhoods throughout the city, and building and strengthening the doula workforce to meet the demand for services. The CDI itself is a model of collaboration with 10 partner programs, including nonprofits, for-profits, and an FQHC. We're integrated into the health department, and we benefit from the passion and expertise of many colleagues there. And we're building strong relationships with clinical partners, getting stronger all the time. So thank you.
Thank you, Mary Powell. That's really incredible work. And finally, we'll have a presentation from Tasia Stewart and Stephanie Visco of Birthmark Doulas.
Hi, everyone. I'm Tasia Stewart from Birthmark Doulas. I'm a member owner. Birthmark is a cooperatively owned collective. And I'm just going to talk a little bit about reducing perinatal morbidity through integrated provider partnerships with community-based perinatal support programs. Next slide. So to give you a little bit of a background of the perinatal support training that I acquired, I went through a program called Perinatal Health Advocate with Sister Midwife Productions. And this was the second doula training that I had in my studies. And I noticed that this training was quite different from other doula trainings. This training sort of taught us to meet clients where they are, especially if they are coming from trauma-informed cases. And also specializing and looking into their mental health and gaining resources if they are coming from affected areas of the population, right? So community-based perinatal support programs, they all come together and need all of the support of the doula, the birth doula, the postpartum doula, the perinatal community healthcare worker, the lactation counselor, the peer counselor, and a certified lactation counselor, and also the International Board Certified Lactation Council, and a nurse home visitor. You can go to the next slide. And this is just to give you a little information about what a doula does. Right now, I am currently working with Covenant House, New Orleans. It's a homeless shelter helping youth between the age of 16 to 22. They also have a maternal pathway home that also houses first-time pregnant moms from that age range also. So day to day, I'm helping them find resources, get signed up with WIC, helping them with lactation and doing childbirth education classes also. So I'm a doula and also a perinatal health advocate. So I help them find community resources also. You can go to the next slide. So this is just to give you a little insight on the doula care and the estimated time giving with the client versus a patient service medical setting. So with prenatal visits, you can see about 3 to 5 hours versus a community-based doula services, you may spend about 8 hours total with that client. And then in postpartum visits, about the same. They may spend about 0.25 hours, and then total, you may spend about 8 hours or more with that client also. In labor and birth, you can spend to the client up to 18 hours versus in the healthcare services, they may be spending about 2, maybe 3 hours with them. So as we go down, we see that the total time with the healthcare services is about 5 hours versus the community-based doula services is about 45 hours spent in total. You can go to the next slide. And this is just to give you a roadmap of the care of the support that is given each client that comes. We review your pregnancy, we give you a birth plan, labor and pain management. We educate on those things. In a second, we talk about stages labor, movement and positioning, comfort measures, postpartum period, and breastfeeding. And then we're on call for you at 38 weeks to 42 weeks. We're continued labor support and support 1 to 2 hours after birth. And then you have your postpartum period where we process the labor, brain, belly, and resources. And then postpartum too, the same. And I think, you can go to the next slide. Not yet, right? So this is just give you a collaborative care provider, doula collaboration. And this is where a perinatal health advocate can support different integrated moms at that time. So maybe someone that's isolated from their family or birthing alone, maybe someone that has experienced domestic violence or a cesarean birth, or desires an unmedicated birth, or has prior loss of miscarriage, or has fear or anxiety of birth or medical settings, has been incarcerated, the LGBTQIA+ community, are vulnerable to postpartum mood disorders, or teen parents. And now Steph is going to do the next slide.
Tasia, thank you for highlighting our direct client services so well. We take a multi-pronged approach at Birthmark. While we started as a direct client services organization, we've grown to encompass more education and advocacy because we realize that this work can't be, we have to attack it from all angles in order to make change. So we started doing a lot more continuing education about like 5 or 6 years ago, including lactation clinics that we offered for healthcare workers, nurses, doulas in the field, as well as quarterly grand rounds that focused on lactation topics or perinatal topics. This slide just shows how all of our case studies that we've collected for those educational offerings have had a very strong trauma-informed framework and a evidence-based framework. And it's also really highlighted or increased the referral process amongst providers in our community. Those topics that Tasia went over on the last slide, almost every one of those points we see as an opportunity for referral. We refer to a local infant loss organization if we're working with somebody who's experiencing loss. We've worked with a language justice organization to translate some of our services, and we've trained them as doulas to work with us as our language justice doulas. So we work really hard not to replicate work where it's already being done really strongly in the community. And so we see it as a lot of opportunities for referrals. And that's it for us.
All right. Well, thank you so much, Tasia and Steph. That was really helpful information. And now we're going to move on to the moderated Q&A. So I'm going to ask all of our panelists some questions, but as we're going through these questions, for our participants who are listening to the panelists speak, as questions come up, please feel free to type them into the chat, and we'll try and get to them at the end of the session. So this very first question is for all the panelists, and it's, what do you see as the tangible programs and resources that you need to grow and support the doula workforce, especially when we're thinking toward or considering the implementation of reimbursement by Medicaid. And that Medicaid reimbursement, of course, typically comes through a Medicaid managed care organization. So, what are the resources and support you need? And we're going to start with Tasia.
So the top resources and support that I think is needed is help with continuing education for the doulas. Also to help support them with their work in education, which means helping them supply manuals, charts, and models to help do their childbirth education classes.
Great. Mary Powell.
Sure. So thinking about the Medicaid reimbursement, especially, I think support enrolling as a Medicaid provider would be hugely important. Also billing, simplifying the claims process. In New York State, a lot of Medicaid is delivered through managed care organizations, and the provider has to contract separately with each one. So it would be fabulous if a Medicaid agency could create a process whereby a doula could enroll with all the MCOs at once. Another thing is that in hospitals, a big issue in our area is that they limit the number of support people, and then they count the doula against that number. So they'll say you can have 2 people with you, but if the mom already has her partner and her own mother, then there's no room for the doula unless one of them leaves. And it's really not fair to ask her to make that choice. So the doula should be in her own category, with not having to compete with anybody else. And then the third thing that I would mention more on a broader level is support for midwives, because the midwifery model of care is really very complementary to the work that doulas do. And to the extent that we can move more towards that model and away from a really medicalized model, I think that will improve things for both doulas and the families they serve.
Yeah, great insights. Bridget?
Yes, so I will mimic everything that Tasia and Mary Powell said. One thing that we do in Indian River, we have the ability to offer bedside lactation support to our moms that deliver at our local hospital. Continuing education is a big one. So in our Grow Doula program, we provide continuing education for our doulas so that they are better equipped with what is coming out that is new. Another thing that I would talk about is like cultural competency and making sure that they understand the community that they are serving and understand the like Tasia and Steph talked about in their presentation, knowing the population that they're going to be taking care of.
Great. And Steph, can you wrap us up on this question?
Yeah, I'm just going to piggyback on the continuing education. I think that there's a great need for community-based, decolonized perspectives on birth work, and that we can find a really rich tradition of continuing education in the community. And I think that also extends not just to the doulas and perinatal community health workers, but I'm also looking for more engagement on the provider side. So interest in education from the providers, interest in these collaborative efforts from the providers and MCOs, whether that means showing up to collaboratives or boards. And yeah, we're looking to bridge the gap between the community-based and the providers. So we all need to be, in the same room, and because we're all stakeholders.
Okay. All right, great points. And now we're going to move on to questions for each of the panelists. So Mary Powell, we're going to start with you. And the question is, how has your program developed and provided comprehensive services, both in the breadth of the services and in the depth of the services? And how have you collaborated with New York City and other stakeholders?
Sure. So our program has sort of added services as we've gone along, as things become clear. It becomes clear that things have been needed. So I mentioned that we started with childbirth education classes through Healthy Start Brooklyn. That's an 8-week series. And then we added in the 9th week, a newborn care class. And then in the 10th week, an infant safety and CPR class. So a birthing family can go through the whole 10-week session or just start, oh, I just learned about this. You're on week 7, but I'm due soon. So go ahead and start, and just, they can take as many classes as they have time for before they deliver. And then it starts all over. We have a fatherhood program that we created more recently. It's both one-on-one services and a fatherhood development class. We also focus on helping the couples strengthen their relationship with each other. We have an evidence-based program called Family Foundations that focuses on communication tools and really talking through what each parent wants for the child before the baby's born. And everything goes haywire and nobody's getting any sleep. So, they can talk about things before and get that, they'll have that to fall back on. We're also focusing a lot on maternal mental health. So we have our doulas do mindfulness exercises with their clients. We have a program called ROSE during pregnancy to reduce the chance of postpartum depression. We have a mental health clinician who provides services to clients and referrals for long-term care. And then she also leads a couple of support groups, one for clients and one for doulas, because there can be a lot of vicarious trauma in this work. And we also have a community action network through Healthy Start Brooklyn. It's people who live and or work in the community, and folks chose to focus on mental health. In terms of New York City, the health department, for a long time, we were just kind of working in our little corner of Brooklyn, but our assistant commissioner became the deputy commissioner for a new division, the Center for Health Equity, and she was elevating our work to leadership. And it became apparent that what we were really doing is kind of piloting work that could be applied more broadly. And so that's what happened with the citywide doula initiative. We work closely with people. So when they got this funding for the visiting program, they said, hey, we need to make sure we include the doula work. So that was a really beautiful thing. And then we were able to bring in a lot of partners that we've been working with over the past 13 years, but we've never had any funding to give them. And so now we are able to do that through the Citywide Doula Initiative, which is really nice.
Yeah, that's so nice to have a citywide initiative and to have the health department participate. I think that is such a key thing in terms of being able to develop these programs.
And
all right.
One other piece, I'm sorry, is that sometimes in the health department, people will say, oh, you really shouldn't be doing direct services. You should subcontract that out. But it's really important that we're doing the direct services because we see what's happening on the ground. Our doulas bring back stories, and then we know where we need to look policy-wise.
Mm-hmm. Yeah, that's a great point. Really helpful point. Okay, so our next question is for Bridget. So Bridget, we're going to talk about the growth of Grow Doula program. And can you talk, both about that growth and then about how you have collaborated with Healthy Start and what that has looked like, how that's contributed to your success?
Okay, I'm off mute now. So the growth of Grow Doula has happened very rapidly. We are a part of, so Grow Doula started through Indian River County Healthy Start Coalition. So we are one of our programs. So one of the things, along with the partnership that we have with our local hospital, we have just sold our model to the Florida Association of Healthy Starts Coalitions. They have been implementing a doula program within the state of Florida, Healthy Start. So eventually all 32 Healthy Starts will have a community doula program, and it'll be the Grow Doula program. So with that structure, we will continue to train the doulas, and they will have a doula coordinator to be able to support them through those times. We will work with them. We talked about in the model, we will continue to work with them to make sure that they are building those relationships with their hospitals first before they have that training, so that there is no barrier for the doulas, so that the doula is a part of the care team. The doula has someone to talk to about issues that may come up with their client. So that is one of the things and how Grow has continued to grow.
Yeah, thank you. All right. Asia, I'm really interested in your response here to this next question, which is how is your work as a perinatal health advocate different from your work as a doula?
Yes, and I know as in the slides, it seems like the work is one and the same, but it truly isn't. As being a perinatal community healthcare worker, like I said before, you're truly meeting the clients where they are. Sometimes it's not solely doula work that we're doing, right? We're helping the client find community resources. We're supporting them in community resources such as maybe helping them get set up with WIC because they may be a barrier there that they may need help with. Helping them maybe find resources to help support with baby items and diaper drives and community baby showers and making sure they have transportation, helping them with medical transportation, getting to and from their doctor's appointments, and then also helping them keep up with those doctor's appointments and make sure they're setting them and going and attending. And also education, providing them with lots of education to be able to understand what is happening at the hospital when they are having their baby in doctor's offices, because some things aren't always explained to the way they can understand them. So I do a lot of explaining procedures and how processes go. And then also checking in with them mentally and making sure that they're in a good space and they're safe. And if not, finding them perinatal support for that. Yes.
Yeah, great, thank you. And then we're going to stick, Tasia, with you and Steph for this next question. So when you look at your work with Covenant House and you think about the way your community is structured, can you talk about different collaborations and how your organization has both collaborated in your community and then, collaborated with different disciplines, taking an interdisciplinary approach?
Right. Well, I can touch a little bit and then I'll let Steph touch a little bit. In some ways that some collaborative care has happened at Covenant House. We have collaborated. There is a program here called Training Grounds, and it provides moms and babies with parent support. So I've had collaborated and referred moms there. There are also, like I said, the Covenant House is also attached to a housing development called Maternal Pathways for first-time pregnant moms. They get an apartment of their own, and I kind of help them recognize the setting or the space that the moms needed to feel comfortable. They provide them with a room for mom and baby, and they're able to stay there, I think, up to 18 months so they can go out into the community and thrive on their own. And I'll let Steph touch on some more things.
Thanks, Tasia. Yeah, I think that Covenant House is one of our richest collaborations in and of itself, and that's a testament to Tasia being so embedded in that work there. The two other things I wanted to speak on, ways that our organization promotes interdisciplinary collaboration. One of the big ones is our Grand Rounds program that I spoke to earlier, which is a quarterly case study program. It started out very small in a local library, and it was just an opportunity for us to look at a case study of a lactation client, because we also have our own lactation clinic. And we would share that case study with the other stakeholders in the community, so nurses, people who work at milk banks, other doulas. And yeah, it would be just in the beginning, like 5 to 10 other modalities represented in the room. And we would share our approaches to working with that client or different opportunities for collaboration that we could see in the case study. That's been going on for about 5 years now, and it's grown in huge ways. There were some shifts definitely with the pandemic when we couldn't do it in person anymore, but it actually brought our work to a much wider audience. And we began doing some perinatal case studies as well. So it's not just lactation. And that's really increased the referral process in the landscape of New Orleans. We've seen that happen where different, we have that connection with the person who works at the milk bank when our client is in need of milk. So the other one is the maternal child health collaborative that we have or coalition in New Orleans, which was founded in 2017. And it's essentially organizations across the maternal child health landscape in New Orleans that come together and meet monthly. And it's been, I think, a fantastic steward of the work and the collaborative work of maternal child health and reproductive justice in New Orleans. And I think that it's also helped us, stay in touch with each other's work and be able to refer out more readily for different providers who are showing up in that space. We see, anywhere from educators or administrators that work at different hospitals to nurses, other doula organizations, people who work with Healthy Starter WIC. And so that's been another really rich place for collaboration and engagement.
Yeah, it sounds like there are so many places you've collaborated, and the collaboration with a housing provider is a really interesting one. Okay, thank you. So now, Bridget, we're going to go on to you. And I think the way your program is set up is so unique and interesting in terms of the way you're collaborating in the hospital setting. So how have you navigated relationships with hospitals and medical providers?
Our CEO has done a really good job with setting the foundation with our hospital CEO, not only just with Grow Doula, but with all of our Healthy Start programs. Our coordinator meets with the director of women's health to talk about any issues or anything that can be taken back to the provider team. We also are, through our Healthy Start, our central intake and referral, our maternity navigator, she is embedded into our OB office. We have only one main OB office in Indian River County. One main one that services our Medicaid clients is what I should specify that as. So they are embedded. So we have a very, very, very close relationship with them. If you haven't already, most participants should have been able to see our Grand Rounds video. It speaks to the relationship that we have been able to build with our hospital and with our providers. We have an opportunity to be invited to our labor and deliveries, their nursing meetings, to answer any questions for them. I make sure that I am available to them, unfortunately, 24/7. But if there are issues that are happening, we want to be able to rectify them. We also support the relationship that we have with them. We offer them on-call doula support. So if they do have a mom that has come in and birthed alone and she has not been established either with one of our doulas or a doula within our community, she still will be able to have doula support and still receive those postpartum visits as well.
Okay, great. Well, this is the last moderated question that's coming up, and then we'll see if some of the people that are participating in this webinar have questions that they want to put in the chat. But the last moderated question is for each of you. What changes would you like to see to facilitate effective collaboration and to really improve interdisciplinary care and integration? What are those changes that you think really need to be in place? And we are going to start with Mary Powell.
Thank you. So I think it's really a delicate balance. Doulas want to be seen and respected as part of the care team because they contribute a lot to improving birth outcomes. But at the same time, they're not clinicians, and their allegiance is really to clients. So if they become literally part of the medical system, they lose their effectiveness. So it's really important for them to be respected on their own terms without having to fit into, a different kind of box. And yet I think also there's an inherent tension because doulas work to center the client, and that's not always the priority for the medical system. So the hospital staff, they have their mandates and their policies and their procedures, and those are there for good reasons. But those policies and procedures haven't always produced the best outcomes, especially for Black women, especially for other people of color, especially for those who've been marginalized by society for all sorts of different reasons. So I think it's really time for a new approach. Some medical providers already collaborate beautifully with doulas, and I would love to see them all do that.
Wonderful. Okay, Bridget.
I really loved Mary Powell's answer. Yes, we would love to see providers collaborate more with doulas and respect, the space that doulas are in when they are with their clients, and also making sure that they understand the work that doulas do. I think some providers don't have that understanding of what we do and what services that we provide to them. We are not there to step on their toes. We are there to be their partner, to take care of the client, the patient together. So making sure that they understand what doula care is, and possibly maybe they go through a doula training themselves so that they understand the structure of the work that we do, and they understand what we are providing to our clients as well, and the support that we give to them.
Great. Tasia?
Yes, I love how Bridget and Mary explained that, and I'm just going to piggyback. I agree with all of the things that they're saying. Also, definitely top thing, provider collaboration, in a sense where the doula still stands on its own. And when I say a collaboration, maybe not necessarily the doula working for the hospital system, but definitely collaborating with providers where they are referred when moms come in and they feel like they need more of a support or help, that the providers are providing all of these doula services that are out there. And then also collaborating with mental health specialists for perinatal support for moms and in the postpartum period. I feel like that is widely disengaged somewhat. I feel like a lot of the times when mothers are going through some mental support, not pregnant, and when they become pregnant, it's like the mental health specialists kind of want to back off and say, hey, I am not versed in pregnancy. So maybe having more collaborative mental health providers for that too.
Yeah, yep, that's a great thought. Steph?
I think all of those points were really well articulated. I think the only thing that's lingering for me is I would love to see more full-time, sustainable, and equitable job opportunities for doulas in their organizations, not just working for other government organizations, but to be able to show up with the experience and knowledge that community-based doulas have. They need to be reimbursed for the time that isn't just spent in direct client care. And in our own organization, we've seen a lot of success in making full-time salaried positions with benefits for our doulas and birth workers so that they can do that core direct client services or community education, but then also show up when the time comes to serve on panels or educate other providers. They're not feeling like they don't have more time to give because they're pulled in different directions, and the tension of having that as a contract job versus your whole job.
Yeah. Okay. Well, great. So I will remind our participants, just put any questions you have in the chat, because we're going to move now into our questions from participants. And I'm going to take a little liberty here and sort of ask a question from my perspective. So since I sit in a managed care organization that's implementing a doula benefit in California, what I really want to know is, from the doula's perspective, from the community health workers' perspective, what do you think the role of the managed care organization should be? Because I think traditionally managed care organizations have often been there to contract with providers to pay for the care. And now we're in this period where they're sort of shifting to being more of a hub for coordination of care and connecting people to services. So, you know, what would you hope from your managed care partners? What should their role be?
So I can start. I would say, you know, you have the power of the purse. So you can pay for the practices that you want to see. And a couple of things that I would start with are to really making sure to reimburse doulas at a livable wage and sort of a thriving wage, not just a living wage. And ask doulas what that is, right? Ask doulas what that includes. I think it was Steph who was talking about all the work that doulas do that's not direct client care, looking up resources and, you know, just being on call is a big thing. And, you know, staying at a birth for 24 hours or 36 hours or even longer. So doulas can tell you what needs to be covered and what that would look like. Another thing I would say is to cover administrative costs for doula organizations. So an organization like By My Side, you know, we have several professional staff people full-time who are recruiting clients, enrolling clients, matching them with doulas, sort of overseeing that relationship. And when we talk about the rates for doula care, it usually doesn't include all of that. It's sort of built around a solo model, but especially for Medicaid patients, I think people have a lot of complex needs sometimes. And so if you can fund also that administrative support, that professional development, that kind of thing, that would be really helpful.
Mm-hmm. Yeah, thank you, Mary Powell. Anyone else?
I think everything Mary Powell said resonated. I also think like understanding the barriers that small community-based organizations and individual doulas face when figuring out like the administrative costs, the operations, I've seen that same reticence from MCOs to kind of like not include those costs in a package or a contract. And we've been navigating signing a contract with several different MCOs for the past like 2 years, essentially, where we've really stuck to our guns with how much we want to be reimbursed, because we know the full scope of that work is so much bigger than the understanding is. So yeah, understanding the barriers, understanding the limitations of an organization that is still like developing our own you know, data collection and electronic medical records practices, like all of that is, you know, takes a lot of investment from a small organization. And so technical support, financial support from MCOs, and at the very least, acknowledging that those barriers exist.
Yeah. Yeah, so I hear, you know, really being thoughtful about the payment models, and what you're paying for is not just the direct care for the client, but also the administrative support, the resources that it takes to build the doula workforce, and that as a managed care plan, you have to be part of all of that, not only because this is a field that is in a growth phase. Okay, well, that's great. Anyone else before I go on to the next question? Well, we may have time for one more question, so we'll go on. We'll try to squeeze one more in. So what are some of the initial steps to help start a community doula group?
I'll touch on that. I feel like some of the initial steps is training, right? Finding that good base training that teaches the doula how to maneuver through the community in the doula practice. I found working as a community doula, like I said, not quite the same as when I was working as just a normal doula that had like middle-class patients and clients and things like that. It looks very different. So making sure the doula is trained and well-versed, like I said, studies that demographic that they're going to be working with, knows that demographic, and also like train to be able to maneuver through the things with that demographic, right? Things look very differently in a sense where sometimes they just need that support. They may not have anyone else, right? It may not necessarily need, you have to pull out all your doula tricks and things. You may not even get to use some of those things with some of these clients. It may just be, I need someone there, right? And just teaching them how to hold that space for those clients. So training, yes.
Training. Well, I think that is a great place to wrap up for today. And I just want to extend my deep gratitude, both for all of you being on the panel today, but for the work that you're doing in your communities, because I think it is really remarkable. And I know that, right now it takes a lot of energy and a lot of dedication and a lot of conviction to do the work each day. So thank you to each of you. And with that, I'm going to hand it back over to Yanti.
Thank you, Dr. Bauer. Also wanted to second all of the thoughts of gratitude to everyone that participated in the session today. So at this time, we want to ask you to complete this brief 3-minute feedback survey. You can access through the link that's in the chat. Everyone should have also received an email with the link to complete today's survey. If you did not receive an email, please contact the IMP team. My email is listed on the slide. And as a reminder, completion of the evaluation is required as part of the learning series participation. We actively review and incorporate your feedback into our future sessions. All materials from today's sessions, including the recording, will be made available to you on the IMI website about 2 weeks after this date of today. And lastly, I wanted to just add that when you register for this learning series, we ask every participant to let us know whether they'd like to, they'd be open to collaborating with others in their state and sharing their contact information. If you answered yes to this question during registration, you should have received an email from me with a table that includes everyone from your state's contact information that also answered yes to that question. Additionally, in that email, I included a link to a survey asking about your interest in receiving technical assistance from the project team, along with others in your state. That survey is going to close tomorrow on June 2nd at midnight. So if you have not completed it, please do so if you have an interest in receiving technical assistance. We are thrilled to announce that based on your feedback, session 8, the final session of this Doula and Perinatal Community Health Worker Learning Series, is going to be operationalizing Medicaid coverage for perinatal support and the nitty-gritty of billing. It's going to be held on Thursday, July 13th at 3 p.m. Eastern Time. So keep an eye out for your pre-session email with the agenda and required pre-session activities. And if you haven't already, please remember to add Jennifer Moore to your email contact list to make sure that you're getting emails about the series and they're not sent to spam. Her email address is also posted on the slide. I want to thank everyone for your participation, and we look forward to seeing you at session 8 on July 13th. Thank you all so much. Have a great rest of your day.